Next speaker is Dr. Vincent Tranchitella. He's a physical medicine and rehabilitation specialist from Lancaster, Pennsylvania. He's a clinical adjunct professor at the Penn State University College of Medicine. He's also past president of the American Association of Neuromuscular and Electrodiagnostic Medicine and a co-author of the AANEM position statement on establishing standard for acceptable waveforms in neuroconduction studies. This is also the title of his talk. Vincent, please.
First, let me say Dobro dan, me veseli. Hope I said that right.
Perfect, thank you.
Well, I'm speaking to you this morning from the morning after Thanksgiving here in the States. Yesterday we had a big feast, and I'm a little tired this morning, so you have to bear with me. So what is Thanksgiving? Thanksgiving is actually modeled after a harvest feast shared by the English colonists, the Pilgrims here in the States, up in Plymouth, Massachusetts, and the Native Americans back in 1621. The original feast actually lasted several days. We just have one day, and it's a good thing because there was a ton of eating. During the American Civil War, President Abraham Lincoln proclaimed this a national day of Thanksgiving. And it was celebrated the first time on November 26, 1863. It is traditionally held on the last Thursday in November. And again, it's a time for family and friends, and it sort of kicks off the holiday season. So I'm not sure you over across the pond get the significance of Thanksgiving, but it is one of our biggest holidays here in the States. So thank you for the introduction. I am truly honored to be speaking with such a distinguished group of internationally renowned electrophysiologic specialists. I'm just a regular guy. I have a private practice. I've been practicing in the States for almost 30 years. I did my medical school at Penn State College of Medicine in Hershey, Pennsylvania. I did my PM&R residency at the Baylor College of Medicine in Houston, Texas. As Blaj said, I was the former president of the American Association of Neuromuscular and Electrodiagnostic Medicine, AANEM. Time is passing quickly by. That was several years ago already. And currently, I'm an advocacy advisor to the AANEM board. I just wanted to give you a little background. When I was asked to present this topic, I was obviously very curious as to where Ljubljana was. I'm here in York, Pennsylvania, which, as you can see, is in the mid-Atlantic area of the States. New York City is just about up in this area. Dr. Sanders, who was immediately before me, is down in the Virginia area. And this is a picture of my clinic. This is my office. I was curious as to where you were located, so I looked it up on Google Maps, and I believe this is your building, if I'm not mistaken.
Indeed, it is, yes.
All right, very good. Next slide, please. I wanted to know how far away I was, so I Google mapped that as well. 7,000 kilometers from York, Pennsylvania to Ljubljana. Next slide, please. Now, interestingly, we're relatively close neighbors. These cities here that I have outlined are where my four grandparents came from. My last name, of course, is Italian. My father's father was from Marsigo Vetri down in southern Italy, but his mother was from Debrecen. My father's father was from Timișoara, and my mother's mother was from Sighet St. Miklos. And here you guys are. So I really wish I was there today to enjoy the beautiful city, your beautiful city, but Of course, this COVID nonsense is a little bit of a restriction. So let's get into the talk. Let's talk about why I was asked to discuss this topic. Next slide, please. So nerve conduction studies. We all know what nerve conduction studies look like. We all do them. Motor nerves, sensory nerves, F waves. Why did we feel it was important to actually develop a position statement on standards for acceptable waveforms? And of course, in a word, the answer is fraud. Not sure how much fraud is existing in Europe, but in the States, fraud in electrodiagnostic medicine is very rampant and very expensive. Next slide, please. So here's some data. These are Medicare claims. Medicare is the government's program to take care of mostly seniors over 65, and they keep track of all the payments for every diagnostic code and procedure code. And you can see here, these blue lines represent the numbers of 95900, which is our motor nerve without F wave. And this is the number represented by neurologists. So you can see from 2002 through 2009, the numbers of motor nerve conduction studies performed relatively stable. Likewise with PM&R physicians, fairly stable. And then you see other practitioners, folks who actually have no training in performing and interpreting electrophysiologic studies. So this is like family practitioners, general practitioners, and other internal medicine. You can see this is a low number, but it's a number that shouldn't exist to begin with. And you can see a gradual and then sudden spike in increased use. It's tapered off a little bit after 2006, but still fairly significant use. Next slide, please. Again, this is just similar data. This is, again, Medicare claims by general practitioners, family practice, and internal medicine physicians for nerve conduction studies from 2002 through 2011. 95904 is our code for sensory nerve conduction studies. 95903 is the motor nerves with F waves, and then 95900 is the motor nerve without F wave. And again, you can see, and remember, this is non-neurologists and non-physiatrists. Just a sort of exponential increase over the early part of the 2000s. It's leveled off, but still a fairly significant number being performed and billed for by folks who do not have the training. Next slide, please. And one more time here, again, a simple graph of the data. 2002, family practitioners, general practitioners, internal medicine. The use of nerve conduction studies, sensory nerve conduction studies, almost, well, it tripled over the course of 4 years, and it's leveled off a little bit, but still, it's still pretty high. Next slide, please. And so here are the numbers. This is from Medicare, the government itself, from 2002 through 2011. Spending for electrodiagnostic testing under Medicare increased from $279 million to $486 million. And so this means spending for electrodiagnostic testing on Medicare beneficiaries alone increased by 74% over those 9 years. Overall, Medicare spending increased 50%. So you can see spending on electrodiagnostic studies has outweighed the spending on Medicare beneficiaries in general. There was a congressional budget report for services rendered to Medicare beneficiaries in 2013. The average number of nerve conduction studies performed on a Medicare patient by a neurologist is 8.45. Average number performed by a physiatrist is 7.74. Look at this, the average number performed at an independent testing facility is 14. So what's going on here? Next slide, please. The U.S. Department of Health and Human Services Office of Inspector General published a report entitled Questionable Billing for Medicare Electrodiagnostic Tests. This came out in April 2014. And after studying the benefits paid in 2011, Medicare paid $486 million for electrodiagnostic tests for 877,000 beneficiaries. 139 million of the billing was found to be questionable. So that's 29% of the billing was found to be questionable, according to this OIG report. Next slide, please. So fraud and abuse in electrodiagnostic medicine comes in many different disguises. There are handheld devices. There are mobile diagnostic labs where a company will send a technologist into a physician's office and allow the technologist to perform a battery of studies following generally a protocol fashion, and then the studies would be read at an off-site by an independent neurologist. This was a way, it was a business model to enable family practitioners to increase their reimbursements without actually going through the process of training for the studies that were being provided in their offices. There's also something called a pain fiber nerve conduction study, which purports to selectively stimulate and record from the A delta sensory nerve fibers. This is an area of my interest in rooting out the fraud in this particular area, and I'm going to show a little bit one of the waveforms or results of these studies. The thing that's common to all fraud and abuse is that the study is performed not for the benefit of the patient, but for the benefit of the provider. In other words, the provider is making money. And as we all know, that is no way to practice medicine. So this is kind of a funny quote here in the States. I know it when I see it. This is actually attributed to a United States Supreme Court Justice, Potter Stewart, back in 1964 in Jacobellis versus Ohio. And he quotes, I quote, I shall not attempt to further define the kinds of material I understand to be embraced within that shorthand description, hardcore pornography, and perhaps I could never succeed in intelligibly doing so. But I know it when I see it. And the motion picture involved in this case is not that. So here this judge really, he had a hard time defining exactly what was hardcore pornography, but he says, I know it when I see it. And this is sort of the same thing here. We know good nerve conduction studies when we see them, but we also know bad waveforms when we see them. And next slide, please. And so this is what we tried to define in the position statement that is referenced in the muscle and nerve. So because of fraud and abuse in electrodiagnostic medicine, there are many of us here in the States that are involved in trying to root out fraud and abuse. And we know that since the quality of the studies does not matter, as I said before, the true purpose of the studies is to provide financial benefit for the provider and no real benefit for the patient. So they don't care about the quality of the studies. And we see this all the time when we review studies performed by bad actors. We know substandard waveforms when we see them. Let me go ahead and show you some examples of waveforms that I have personally reviewed that were submitted for reimbursement and were utilized to diagnose the condition of a patient. Here's a substandard sensory nerve conduction study. You can see left sural sensory nerve. Look at this huge stimulus artifact saturation. Also take note, look at the parameters here. We've got a gain of 50 microvolts per division, which means if you're going to have a sensory nerve conduction study, sural sensory nerve of about 10 to 15 microvolts, you're only going to see a tiny little blip. So this obviously is the inappropriate setting for this particular wave nerve conduction study. And also 2 milliseconds per division. So that sural sensory nerve, assuming it might be normal, would probably be somewhere in about this area. You're never going to see that here with these settings. Next slide, please. This is an example of an F wave. Where is the F wave? What are we looking at here? It's a bunch of nonsense. Also note that the provider only performed 3 stimulations. We know standard of care is to obtain at least 10 F waves to accurately measure most accurately measure the minimal latency of the F wave. Also notice the sweep speed. We have a left perineal, and we've got 1, 2, 3. So this latency is about 35 milliseconds, which is probably pretty fast for someone unless they're very short. But this is what was reported as the actual F-wave latency. I suspect the F-wave may be in here somewhere, but again, this is completely substandard and should never be submitted for analysis and for reimbursement. Go ahead to the next slide, please. And this is an example of what we see with the pain fiber nerve conduction study results. Notice here, this is supposed to be measuring the alpha delta response, selectively measuring the alpha delta response to selective A delta stimulation. And as we know, if you would ever potentially see something like that with surface recordings, it is going to be probably less than a couple of microvolts at best. Well, look at the waveforms or the parameters here, microvolts. These waveforms are up at about 50 to 70 microvolts, which you don't normally see with standard or routine nerve conduction studies. And then also look at the x-axis here, it's in seconds. So again, this makes no sense, but this is what's being presented and submitted for diagnostic purposes and for reimbursement purposes. But we don't even know what this is. Actually, Sanjeev, Dr. Nandekar, who speaks later than I, he and I did a bit of a study on what this actually represents, and it actually represents just stimulus artifact. But again, there are thousands of people who are being studied with this particular technique and are being told they have neurophysiologic problems based on what is actually junk. Next slide, please. So going back to the old statement, we know it when we see it. We all know that those last 3 slides represented basically nothing, and so we felt like we needed to have a definition to apply. We needed a standard to apply when we were analyzing cases for potential fraud. We encouraged the AANEM to develop a position statement, and because I was one of the ones who was sort of vocal in this field, I was tabbed to help write the position statement. Next slide, please. So we sat down with a group of us and we wrote some parameters, and basically it's just defining what we already know. Establishing standards for acceptable waveforms in nerve conduction studies. It was written by myself and a few other members of the professional practice committee of the AANEM. The AANEM board of directors approved the position statement last summer, and it was finally published in Muscle and Nerve in 2020. And we had some wonderful feedback from 2 of your panelists today, Dr. Stolberg and Dr. Nandekar, regarding the position statement. Next slide, please. So basically, we just concentrated on waveforms produced during your standard nerve conduction studies, sensory nerve action potentials, compound motor action potentials, mixed nerve action potentials, F waves, and H reflexes. We wanted to basically define what parameters should be used to measure nerve function. We really didn't discuss the central studies or electromyography. Next slide, please. So our position statement talks about techniques to minimize noise and maximize the accuracy, reliability of the generated nerve conduction study. These techniques have been described in all major EDX textbooks and didn't really need to be reiterated, and I'm not going to go over those here, but they are part of the position statement. There are some patient-specific factors to address, including their age, body habitus, limb temperature, edema, tolerance to testing. Obviously, to obtain a quality waveform, we need to utilize these techniques to minimize noise and maximize the physiologic response. We want to accurately measure the onset of the waveform, the peak of the waveform, the trough, and the return to baseline. Go ahead to the next slide, please. We need to have an instrument that has the appropriate instrument settings to obtain these waveforms. The settings or the instrument needs to have an appropriate gain, sweep speed, and filter settings to actually capture the neurophysiologic responses that we're interested in. These instruments must include a differential amplifier, which improves signal-to-noise ratio, a gain capable of acquiring anywhere from 1 microvolt to 10 millivolts per division, a sweep speed range of 0.1 to 500 milliseconds per division, and in filters capable of creating an appropriate bandwidth to see the neurophysiologic response. Again, low frequency filter from 1 to 2000 hertz with a high frequency filter 100 to 10,000 hertz, and a notch filter at 50 or 60 hertz for the ambient electrical interference noise. Next slide, please. So characteristics of an acceptable nerve conduction study waveform include clearly identifiable polarity, configuration, onset, peak, and return to baseline. And of course, this is the only way to accurately assess the parameters of amplitude and conduction speed, either at a distal latency at a fixed distance or a conduction velocity. And we all know this. Again, next slide, please. So I'm going to show you some examples of appropriate waveforms, acceptable waveforms. This is a sensory nerve action potential. Notice the appropriate gain settings and sweep settings, 1 millisecond per division, 10 microvolts. So this response, this sensory nerve response, is basically right in the middle of the screen. We have a clearly identifiable onset, peak, trough, and return to baseline. Next slide, please. Same thing here with the motor nerve conduction study. I think this was the ulnar motor nerve. Again, no problems with this. We know it when we see it. Clearly identifiable waveform, the parameters of which we can accurately use to measure the patient's neurophysiologic status. Next slide, please. And this is an F-wave study. Again, note that the standard dictates at least 10 F-waves are obtained to accurately measure the minimal latency. And again, the F-wave has been set up, the screen, the parameters, the settings, the filter settings have been set up so that we can capture what we're looking for. Next slide, please. So to ensure quality, these waveforms must be reviewed in real time and on site by the provider. The accurate reporting of the waveform's amplitude and conduction speed is required by the CPT. That's the American Medical Association's current procedural terminology in order to submit billing for nerve conduction studies. So in order to get paid, you must report the waveform amplitude and the conduction speed, obviously the result of the study. And if you can't accurately measure these, you really should not use them, number one, for diagnostic purposes, and you should not submit them for reimbursement. Next slide, please. And so really, it's very simple. I feel a little sheepish speaking to you among the other speakers who are presenting some very, very interesting and important topics. And this is just kind of restating the obvious. An acceptable nerve conduction study waveform should clearly have an identifiable polarity, configuration, onset, peak, return to baseline. If these parameters cannot be clearly identified, then the amplitude and speed of nerve conduction cannot accurately be assessed, obviously. In these cases, the waveform is then considered substandard and should not be used as a measure of the patient's neurophysiologic status, and certainly should not be submitted for reimbursement. Next slide, please. I believe this is what I'm missing out on this week, and I could have enjoyed the beautiful sights of your city. But unfortunately, I'm stuck here in my office back in Pennsylvania. Next slide, please. And I'd like to say Hvala Lepa. Many thanks for paying attention, and I'll be happy to take any questions now.
Hvala Lepa, Vincent. I can tell you that it's very gray outside today in Ljubljana, so you're not missing much. I think it's okay to wait for the sun to come out in a couple of months' time, and I'm sure there will be an opportunity for you to visit us here. We have a comment from Professor Stolberg. Interestingly, he said, he wrote that the slide on F wave, the peroneal nerve with wavy baseline, he's commenting that the disturbance was not seen before the CMAP, and was wondering whether it could have been a real cholinergic MG or otherwise hyperactive end plates. Could you comment on this?
What I would believe in these situations is, and this is what typically happens, I would tend to say no. I think this is just substandard technique. What we see in these cases of fraud, and again, this particular waveform came from a case that I reviewed, and this is a common theme. And when I review cases, I'm looking at a sample of the provider's studies, and so I might look at 50 studies from 30 patients, or upper and lower limb studies are considered different studies, but I might look at 50 to 70 or so electrodiagnostic studies performed by this provider or this provider's group on patients, and that disturbance that we see is over and over and over again in patients. And what it is, it's basically just they're slapping recording electrodes on patients. They're not performing the appropriate techniques to obtain quality waveforms because they don't care about the response. So a lot of times this is just electrical noise because of poor recording techniques. And I'm not sure I actually answered your question, Eric, but I'll be happy to take another stab at it if I did not.
Maybe we can ask Eric to comment. Vincent, can I ask you, do you think that waveforms, the images of waveforms should be part of the report that we produce? Because sometimes, at least in Slovenia, some people would include them as a part of the standard report given out by the machine itself. Sometimes we do not include them. What do you think?
Well, I think it's high time that, that's an excellent question. I think it is high time that we require the waveforms to be submitted. And so here's the story. I've been with the AANEM. I've been an active volunteer since the late 1990s. And I remember the folks in the prior generation, folks who have now retired, having this discussion several different times. And back in the days, and I'm old enough to remember, and in fact, I have an old machine where we used to have a little strip of paper print out the waveforms if we wanted to. And it was such an onerous procedure back in the analog days to print waveforms and include them with the reports, that the AANEM came up with a position statement back then that said, you know, waveforms are nice, but they're not required as part of the report. Well, now that everything's digital and we all have these beautiful machines that with a push of a button can easily include the waveforms with the report, I think it is time that we revisit that position statement and update it. And in fact, I have said this previously, and I think the AANEM has been slowly waiting for my predecessors to no longer practice or to not have a strong voice opposing the submission of waveforms. But that's an excellent question, and I think they should be included in all reports. Otherwise, what are you hiding, right?
Can I make a comment?
Yes, sir.
Vincent, thank you very much. A very important lecture you are giving. I like it very much. That particular slide that I commented on is exactly what I saw in one patient with a muscle myasthenia, and the question was naturally that it was disturbances or bad recording in some way, but it was actually a severe overdose of mestinon in that patient. They are particularly sensitive, so one should be ready for the unexpected. But
Yeah,
otherwise, I agree with you completely. Naturally,
well, that's an
they
excellent.
disappear. They may these may disappear on after a few seconds of activation, strong activation, and then it disappears.
Well, I appreciate that input. It's an excellent comment. When I review these cases, I also have the ability to review the initial history and physical exam. And the bottom line, you're looking at patients with real problems. These folks, unfortunately, have the problems of pain. Typically, we see this fraud. These fraud actors work in the arena of either workers' compensation or motor vehicle accidents. And after a motor vehicle accident, of course, everybody is told they have neck pain and back pain. And so the folks that are actually getting these studies are generally very healthy folks who unfortunately had a car accident and have neck pain or back pain and maybe some symptoms into limbs, but they don't truly have any neurophysiologic problems. And so that's how we know that these are all, it's all nonsense. It is purely a way to increase reimbursement and to make money.
Okay, thank you very much. Thanks a lot.
Yes, thank you. I appreciate it.